Welcome to this SASTM podcast. I'm Garth Brink, and I will be in discussion with Professor Martin Haditsch on aspects of the COVID-19 pandemic. Martin is based in Austria and is well known in travel medicine circles. He has graced our shores on several occasions, and many would have met him at our conferences. After 20 years of work in an Austrian hospital focusing on clinical microbiology, parasitology, tropical and travel medicine, as well as vaccinology, and running a travel medicine clinic, which included a yellow fever vaccination center. In 2010, he became head of a microbiological laboratory in Hanover. He is co-founder of the Austrian Society of Travel and Touristic Medicine. He is a board member of the Austrian Society of Tropical Medicine, Parasitology and Migration Medicine. He is member of the editorial boards of the Journal of Travel Medicine and Travel Medicine and Infectious Disease. He is also a member of the SASTM Examination Committee and the Responsible Travel Interest Group. He is the international advisor to the Asia Pacific Travel Health Society, as well as a member of a medical expert committee counseling the Austrian Ministry of Defense. So Martin, thank you for joining me in this discussion on COVID-19, and it's a privilege to be able to speak to you, having listened to a number of your YouTube and other video conferencing that you have had on this particular topic.
Thank you very much, Garth. It's a pleasure to talk with you on this topic, and apologies for my maybe sometimes not so good English. It's not my first language, but I try to do my very best.
It's not a problem at all, because we're all talking about the same thing, and very often terminology is the same, so there should be no difficulty in understanding at all. I really do appreciate it. So I think one of the things that really caught us unawares was the rapidity by which the SARS-CoV-2 virus spread. We know what's happened previously with the SARS infections and how rapidly it spread, mainly due to air travel. But that was able to be contained. This pandemic has caused immense global fear and panic, and it has caused disruption that is immeasurable, humanitarian and economically, which of course is far worse in developing countries and where there is a limitation of resources. One of the videos I watched in which you participated, you mentioned the need for a world summit where various experts got together, such as economic experts, epidemiologists, scientists, to discuss and determine the basic ground rules. The social and economic harm that has resulted is unimaginable, and one from which we, in South Africa, and I'm sure from other developing countries as well, will take decades to recover. On looking back, what lessons, if any, do you think we have learned?
Well, as we all are aware, this kind of pandemic is dominated in those countries by virologists and politicians. Yet this kind of pandemic also is touching and is infiltrating other areas of expertise who were not able to participate in the discussion, and as well in what we call the structural problems, which are dealing with how to get across with this pandemic. I mean, the lessons we have learned are poor, but there are some. There are, in terms of medical expertise, there are some lessons. We've seen that obviously SARS-CoV-2 can be treated, or the symptoms related to can be treated quite well with anticoagulants, because obviously thrombosis is one of the main pathogenetic models, and that we have to deal with some kind of an overreaction of the immune system. Thus, we should try to figure out how deep this infection is going, and the inflammation and anti-inflammatory substances also contribute a lot to the survival rate of those who are infected. We don't have an antiviral agent which has already shown real good action. I mean, you all know those stories about remdesivir and so on, but these are the main, what I illustrated, these are main steps forward in treating patients. So we have learned some lessons in the medical aspects. In terms of the strategics, we have learned only little. I mean, you all know that discussions about the masks, and it's in some areas even mandatory to use and to wear masks, whereas there is no scientific proof that this works. And the same is true for social distancing. We could still talk about it, but even there is no scientific proof. And in terms of political or economical terms, I think we didn't learn any lesson. So my impression is that those who decide on the problems, their most important goal now is not to lose their faces and somehow to defend the measures taken which were inappropriate and which were by far overestimating what is going on.
So this gets back to statistics and how one interprets the statistics that we have. And yes, we'll come back to the masks and social distancing a little bit later in our discussion. So if I look today, 11 August, the figures that we have at the present moment in South Africa is 559,859 confirmed cases. The number of tests, just over 3 million, 3,250,583. But of these tests that were done, we cannot be sure if those who were tested had any symptoms, or were they tested because they were being admitted to a hospital for a procedure, or was this part of contact tracing? And were they being retested to ensure that they were negative prior to returning to work? Because early on in the outbreak, this was considered to be the norm, and they had to be retested until they had a negative PCR test. We've had 10,408 deaths. They report 474,000 recoveries, but it must be a lot more than that, because we really don't know how many people we haven't tested who actually have had the actual illness. So there must be a lot more recoveries, and the incidence prevalence is a lot different to what we see in these figures. This gives us an infection fatality rate of 1.9%. But as I mentioned, I think the prevalence must be much higher, as is the incidence. And many have remained asymptomatic. They didn't present for testing. They didn't feel sick. They contracted the illness. And there are those who were indeed symptomatic, but we didn't test them. There was a cry, as it were, or a plea from our pathology laboratories in the private sector to please be circumspect about who we sent for testing, as the kits were certainly numbered and we didn't have sufficient that would be required if there was a major further outbreak and people who required them. So we have some statistics, but really, does this give us an accurate indication of what is happening? And to what extent is this statistics that we have creating more fear and panic than perhaps is really warranted?
Well, you see, I think the story starts with terminology. You have cited the number of confirmed cases. And that's my first point. Were these really cases? How do you identify a case? It's usual that in medical science, a case is somebody who is sick or who will develop sickness if we don't interfere. Usually, I would say what you have with these 559,859 cases, what you said cases, these are proven infections. But
I would
not, these are not medical cases. They are not sick. But people who listen to this, they think, in the public, they think, oh God, there are so many sick people, which is not true. And I think it's the same in our region with television and with radio and so on. They talk about cases and make people feel, the public feel, that there are so many sick people, which is not true. Because we have a lot of people, it's the majority of people, who don't get sick when they are infected. This is up to 85%. It depends, of course, on the age of the underlying diseases of the healthcare system, whether people stay healthy or whether they have underlying diseases and so on. But on the average, it's in between 50 and 85% that they don't even get sick. The other thing is we have a tool, an excellent tool, which is PCR testing. And this fuels the statistics. But I see major problems, first of all, in the timing of doing the PCR. So you might get false negatives if you test too early. You might get false positives if you test twice. And in the second time, it's positive still, but it's counted double. You may get false positive because the primers don't match that good to the targets you have, which are specific for SARS-CoV-2. So you might also detect other coronaviruses. And these are the problems which are, I would say, which you have to face with any test you do. And the PCR, it's the crown of testing in infectology. It's the best we have. But still, we have to take into account that we do have some, I would say, problems with the sensitivity and the specificity of the tests. And the lower the prevalence, the higher the likelihood that the positive result is false positive. So we have to take this into account when we talk about figures. And something which is, or let me just mention two additional points. The one thing is, if you only give absolute numbers and you don't take these numbers per day in conjunction with or in relation to the tests done on this day, and if you don't have a percentage of positivity, you won't be able to define a trend. If you test more, you will have more positive cases, so you can play with these figures as it fits into your concept. The other thing is, we have seen that SARS-CoV-2 frequently follows an infectious model like outbreaks. It's mini outbreaks. So if you have somebody, they call it the super spreader, if you have one person able to infect a lot of other people, then you have a mini outbreak in this region, but this is not indicating the trend. So if you have this, if you just take these figures and follow up the general trend, you will see these outbreaks are not indicating a trend in a bad direction. These are only outbreaks as an isolated thing, and the general trend will stay the same, which in most countries now means it goes down.
So I think this is a very valid point, and the positive cases that we refer to here, I'm sure, are based on PCR testing. And already this highlights some of the problems that you've actually outlined as to the validity of these tests. Another aspect which I'm sure one has to think about here is the technique, and from where the swab is taken, time to laboratory, and ability to actually perform the test.
may I just add a little bit on your figures? You said that the infection fatality rate in South Africa is 1.9%. I'm absolutely with you. This can't be true. I've been to South Africa a few times. Also, thank you very much for the invitations to come over to the conferences. And I know that South Africa, on the average, it has a quite good healthcare system. And if you take areas where the healthcare system is not as good as in South Africa, for instance, in big cities like New York City in the United States of America, where you have a lot of poor people, where you have no access to the healthcare system or a very limited access to the healthcare system, where you have a lot, especially amongst the Black people, people with underlying diseases, the trend to go to the hospital as late as possible because they don't want to go to the hospitals because this might also cost a lot and they don't have the money and so on. Even there, the infection fatality rate was corrected and now put to 0.5%. So I can't imagine that in South Africa, it's 4 times the case fatality or infection fatality rate of New York. This can't be true. So what's the point? As you already said, the denominator must be very much higher to bring this percentage down. And I'm sure, and you're absolutely right, I think you will have much more positives who haven't fallen sick and who might contribute to the correcting this figure of 1.9%.
Yeah, thank you. I agree with that totally. And it's inconceivable to think that our infection fatality rate is actually so high. But this brings us to another point, and I think this is sometimes common with a lot of the infectious diseases, is that why some people, and we talked about super spreaders, who are considered to be a high-risk exposure, do not seem to contract COVID-19. And I've seen this in households, and I'm sure many other people have as well, where one member has contracted COVID-19, they've tested positive on the PCR, and none of the other members seem to contract it. And yet we have the situation where someone contracts COVID-19 and we try and trace the source of the infection, and we just can't seem to think where they would have actually managed to pick it up. And we've seen this in other infectious diseases, and I can recall very often in my early days of practice, particularly chickenpox. We used to see regular outbreaks, and this was before the vaccine came onto the scene, which reduced the number of infections quite considerably, is that if a child contracted chickenpox, the mother would ensure that the other children became close contacts of that particular child. They didn't keep them apart, and yet they didn't contract chickenpox. And yet 5 years later, they managed to contract it. So there seems to be some susceptibility, or the person seems to be at a right time, shall we say, to actually contract that COVID-19 infection. Is there any reason why that susceptibility changes? And likewise, we see this with influenza as well. Some people just don't seem to develop influenza year after year after year, and hence the reason why they don't have an influenza vaccine. But 1 year will happen and suddenly they will contract it. So it's an interesting, to me, an interesting thought as to what is the immune system doing here that suddenly it's managing to prevent an infection taking place at certain times and other times allowing it. And I'm not talking about people with comorbid and underlying conditions or immune compromised. I'm talking about a normal, so-called normal healthy individual with an intact immune response system.
Well, you see, I'm absolutely with you. I think the chances to get it are quite different, and this is individual. And I think we have to take into account that, well, the first thing is we have to accept, and I use this word because the mainstream thinking is different. We have to accept that SARS-CoV-2 is not highly contagious. I know that there are stories about this basic reproduction number going up to 5.7 or whatever, starting with 1.3, and it depends on the circumstances and so on. But in general, I would say it may be something like 2, 2.5, but this is not highly contagious. You know, and you already addressed chickenpox, this is highly contagious. Measles, this is highly contagious, but it's not with SARS-CoV-2. So the chances are different and it's not highly contagious. The question, how to judge on whether somebody has been infected or not, is not so easy to be answered, because you see, we are used to take seroconversion as the main point to identify whether there was an infection or not. But this obviously is not true. We've seen that even the barrier on the throat might contribute as the first line of defense. So if you have no even slight co-infections, we know that with influenza and pneumococcal disease, they are playing together. And maybe there are some other infections that play a crucial role, whether or not SARS-CoV-2 acts as an infectious agent or not. We can't measure this, but this might contribute highly to it. We know that there might be specific immunoglobulins of the class IgA, which is bound to the mucous membranes, that might act, but we can't measure it in the blood. And this might be an explanation. We don't know it. We don't have really hard scientific data for it, but let's just think about it. This might be a reason why children don't fall sick or not severely sick, because children are repeatedly exposed to coronaviruses. And there might be some kind of cross protection, not only cross reaction in the lab, but also cross protection on the basis of these IgA antibodies we cannot measure in the blood. So maybe they don't get sick. And if you say, I want to know whether they are infected or not, and you just take the blood, you won't find signs of infection. So you say they haven't been infected, but maybe they were. And the same is true for, we are only measuring what we call I would say, those antibody dependent defense system. But we know that we do have killer cells. And there was just now a publication that showed that T cells might confer immunity. They are a line of defense against SARS-CoV-2. We don't measure it. We cannot measure it, but it works. So there might be several lines of defense, and we only measure one of those. And this will also be very tricky if we want to check immunity due to vaccination, because this also acts on various lines of defense. And we will have, and this will be quite challenging, we will have to judge on immunity maybe in a different way.
So this comes back to another question which we've partially addressed, and that was, how do we minimize the risk of contracting this infection? Already you've stated that it's not as infectious as people think it to be. And you've said that the wearing of masks and social distancing, that there's no scientific evidence to show that this is of any value. And yet it is, in our country, it is proposed as being the most important. And that you almost get frowned upon that if you don't wear a mask, then you are taking an unnecessary risk and you're not playing your part. And if you walk into offices and things now, they have screens in front of them to minimize droplet spread and contamination. For instance, and we've mentioned that in New Zealand, wearing of masks was not enforced. And also social distancing in some areas is just not feasible. People get quite concerned about surface contamination as a major source of infection, and they go shopping, and as soon as they come home with whatever parcels, they are sprayed and cleaned and goodness knows what else before they are placed away. And the parcels and the packets are all disinfected prior to placing them in their various places at home. Shoes are then taken off on entering the home and washed thoroughly to ensure that there's no contamination. So considering, and particularly when I'm dealing with my older patients and they are concerned, what do we need to try and say to them other than isolating themselves, which is really not necessary, I think, to try and minimize their risk of contracting this infection?
Well, there are maybe three major points you mentioned, and please let me comment on that. The first is the wearing of the masks. I assume in South Africa it would be the same situation as in Central Europe, that people simply cannot afford or have no access to masks fitting the conditions of FFP2 or FFP3. These are masks that could protect you against viruses.
I'm talking about the N95.
And they are tightened all around the nose and the mouth, and it's quite difficult to breathe when you wear this kind of mask. So alternatively, at least in our region, people tend to wear, if ever, surgical masks or homemade masks, whatever. So they produce the masks themselves, or they get it via the internet or whatever. And if you take the upper part of the quality of these masks, you end up with the surgical mask, what is usually used. So what is the intention of a surgical mask? The intention of a surgical mask is to block out bacteria from the breath of the surgeon so that he doesn't blow his bacteria into the surgical wound. So what is the capability of this mask? To block out bacteria by the one who wears the mask. But it does not block out viruses which are in the environment. So it has a whole different intention. And all the other masks which are used and which are of lower quality as compared to the surgical mask, how should they be able to block out viruses in the environment, especially if you see how they are worn, how often they are worn, where they are worn, by whom they are worn, and whether they really cover nose and mouth. In most instances, it's on the lower part only, so it just covers the mouth. So everybody who is able to reflect on logical basis, how could this kind of mask avoid an infection by a virus? It's impossible. And we even have those face shields, which are open on both sides and on the bottom. You get scientific literature that the viruses may survive in the environment for 4 or up to 8 hours or whatever. So if this was true, and if this was of clinical relevance, all these masks must fail. They cannot work. So what is the basic reason to have these masks as a tool to avoid a viral infection? It cannot work. Point 2, social distancing. You know about the studies where one family member was infected. and even was sick and stayed at home in a closed environment with very close relationship to all the other family members. And you heard about the publications that maybe the infection would be highest in the time before they fall sick. So especially then, there would be a very intense interaction in between the family members with hugging and kissing and everything because everybody is healthy. And even then, those infections don't take place. You have family members who are, I would say, jailed up together in a very small environment with closed windows, whatever, and infection does not take place. So how should social distancing work? What's the idea? If even in this very closed compartments, infection does not take place in every instance. There are other mechanisms, and social distancing, there is one thing that has proven some effect. This was the avoidance of mass gatherings. Because if you have many, many people coming together in a limited space, the likelihood that amongst tens of thousands of people, there is one maybe super spreader, and this person causes maybe a little outbreak, this is higher if you have a big number of people coming together as compared to small. So this is okay, but there is not one single proven outbreak related to a supermarket. So why should we have social distancing and wearing of masks in supermarkets? Many of these things are based on activism. There are certain rules put in action or put in place so that people don't ask the real important questions, which means what is proven efficacy? And there is, as you see, no real answer, especially not to masks and social distancing.
And if we talk about surface contamination?
Well, you see, we know that surfaces may be contaminated by viral agents. There were few tests that tried to check the potential to multiplicate after a certain time on a surface. So there were tests where the surfaces, there were swabs on the surfaces, and this substance was brought into liquid cultures with cells where the virus could grow again. And it was shown that there was a certain survival time of this virus. And survival time is not really correct because, as you know, a virus is not it's not a living agent. It's somewhere in between life and not life. So, but it could be cultivated again in these cells. But this does not necessarily mean that it can infect. And if you reflect most of the situations, in 99%, you can trace back a disease, a sick person can trace back the infection to a person that had symptoms. So the main source of infection are symptomatic infected patients. Because due to coughing, sneezing, and so on, they don't need an additional vector to transmit the agent to another person. Of course, if you give intense kisses or whatever, or if you go into the throat of another person with your fingers because you want to feel whether the tooth is loose or not, and then you put those wet fingers into your own mouth, you might be able to transmit the disease. But that's not what people usually do, especially not if some person is sick.
No, correct. So, nonetheless, I still think one has to be cautious. I don't think that it means that we can throw all this out the window. And I think most of it is probably to try and protect those who might be asymptomatic and spreading it to other people. But as you say, it doesn't stop the viral shedding at all, and also exposure to the virus. The mask won't stop it unless it's a close-fitting type of N95 mask that the person is wearing. So moving on a little bit more, and we know that there's a vaccine being trialed in South Africa. We've talked a little bit about serology, but if we think about the post-COVID-19 period, and now this relates to travel medicine, which we are obviously all involved in, do you think there are going to be certain requirements that the traveler will have to meet in order to travel? Will certain countries be applying certain restrictions? If the vaccine is available, do you think that they're going to say proof of vaccination is necessary? We don't know about serology and how accurate that's going to be to state that there will be indeed immunity conferred. How do you think this is going to affect future travel relating to the traveler, particularly internationally? It might not be so much of a problem in the country itself, but if they are going to, say, from South Africa, a hot spot at the moment, to Australia, well, Australia's not letting anyone in, but once we get to the stage when international travel is permitted on a larger scale, what do you think is going to be instituted and required of the traveler?
Well, you see, there is such a lot of irrationality now in action that I don't dare to do any prophecies because it's very, very difficult. I don't know which are the real goals that are behind these stories. Because if we talk it seriously on basic, excuse me, on basic medical epidemiological facts, who would ever have done all this when dealing with an agent that causes disease in less than half of the infected people, severe disease that causes hospitalization in 5 to 10%, and with an infection fatality rate of roughly 0.5%. I mean, if this is adequate, what we do now, why didn't we do it a few years ago with the flu pandemic? Or
exactly.
with even the seasonal flu, when the B strain, Yamagata, was responsible for a lot of cases. I can just give you the figures of Germany now. We have roughly 9,300 deaths now attributed to COVID-19. Some of those were not caused by SARS-CoV-2, but are allocated to this kind of disease. While we had roughly 25,000 influenza deaths 2 years ago. So it's not, it's inappropriate what's going on now. So I don't want to give any predictions. But what I must say is, I'm not in favor of a fast-track vaccine, which might cause even severe symptoms in those vaccinated. We've seen with the tests with the SARS-CoV-1 vaccine, which is now 15 years ago, that in the animal model, the mice vaccinated had more severe disease when challenged with SARS-CoV as compared to those not vaccinated due to some kind of hyperimmune response. So that's something we have to take into account. I know that some companies, of course, take care of this event as well. But we have now far more than 100 companies trying to find a vaccine against SARS-CoV-2. But doing it on a fast track means that we will miss some of the adverse reactions, and this might fire back. And not only on the SARS-CoV-2 vaccine, but on whole vaccinology. Now we have those anti-vaxxers. They're only waiting for this event, and then they can say, we always told you vaccinations are bad. And this will be some kind of generalization. And in terms of travel, I mean, did we really care for travelers that they got their shots against flu when they were traveling, especially to the other hemisphere or during the flu season? Was this first priority? No, it was not. And now we are dealing with, I mean, the whole world is dealing with this pandemic as if there was only one infectious agent now important, and this is SARS-CoV-2. And if there was only one important reason for dying, and this is COVID-19. So this is some kind, one must assume this is some kind of a scapegoat for something else happening. Now, it's responsible for everything. Everything bad that is now happening on our Mother Earth is attributed to SARS-CoV-2 and to COVID-19. And in terms of travel, I mean, we know that it is simply not possible to somehow to confine the area to a certain region. And you know that China, in the first step, they tried somehow to do containment, but it did not work, and it cannot work. And it cannot work with SARS-CoV-2, and it won't work with other bugs which are still to come. And I think our big challenge is to get rid of this irrational fear. We have to offer protection to those in need, but we should not force them. I think it's a basic principle of ethics that there is autonomy and that they may judge on the amount of protection they want to take. And it's not up to us to tell them what to do. And of course, it's a multi-layer situation, and they should be informed to their best, but they should not be locked up anywhere if they don't want to be locked up. And protection always means offering it to them. And maybe for those, one of the vaccines might confer an additional value, but up to 85%, it won't be necessary. And I mean, there are people who did some estimates, and they said that if you find seropositivity in 20 to 25%, it's quite likely that you will have immunity in roughly 100%. Because immunity might be due to other factors. And I ask you, and I ask to those who listen to this podcast, why is it that if in some region you have an outbreak of SARS-CoV-2, the infection rate won't be any higher with PCRs and so on than 20, 25%, and then it decreases again. And we've seen this phenomenon for instance, in Germany before the lockdown. So the lockdown was after the starting of the decrease. The decrease was already on the way when they after having had the peak of the disease, they pronounced the lockdown, which was irrational too, because of course they claimed that the lockdown was responsible for the decrease of cases, but this was not true. And you can take these pictures; they are in the internet. You can look them up. It's not a story I invented, but it's true. This is facts.
In South Africa, though, we did start our lockdown, I think, quite early. And subsequent to when we got to level 3, there was a sudden surge of infections that occurred, and it's still continuing. So I think in conclusion, one comes to the thought that one's lost perspective somewhat on this infection, that, as you pointed out, influenza deaths that you are experiencing or experienced them some years ago, much higher than what we're experiencing with COVID presently. So why all this extreme lengths to which people are going, and well, governments and so on, authorities, banning alcohol and cigarette bans as well, which one can say have benefit long term. But is that really necessary? But that obviously is the policymakers' decisions as to what is going to happen or what isn't going to happen. And I think that it highlights most succinctly the fact that one has to try and take all the evidence into account and to come to a rational decision as to what is the best to do in the interest of the community. And to what extent does one actually impose on the freedom of the individual and individual's rights? So again, and I think there's been quite a clamor in South Africa that we've been through probably the worst, and it seems as though there is a decrease in certain areas in terms of COVID-19 infection. To say this is what we've got, it's up to the individual to make that decision, him or herself, as to the protection that they're prepared to actually make sure that they minimize their risk and to allow business to continue as normal. So it's a complex issue, and there are lots of role players in this. And just for your final comments.
Well, you see, what we as doctors should try also to communicate to the public is, first of all, that we have a duty, and this duty is to care for the people. And this mandatorily has also to include collateral damages by actions taken. The collateral damage in Germany alone, due to postponed surgical interventions, to interrupted cancer treatments and so on, will add up to in between 5 and 125,000 deaths attributed to non-medical care. So as compared to 9,300 COVID deaths. So we have to take this into account, and we have to care. It's not worse to die to COVID-19 as compared to breast cancer of a woman who didn't get her radiology done on her breast because she was not allowed to go to the hospital to have an X-ray checkup. So I think we have to take a balanced position. And this means also not to put far more pressure on SARS-CoV-2 as compared to other infectious diseases or non-infectious diseases. I think it's our duty to care for the people, which also means that we have to give them hope into future, positive thinking, to allow them to build immunity, which also means to go out, to have nice events, to have positive events in lifetime. And it's not to block out everything, just not to get infected by one very special, not very infective bug. And you see, if we don't build up trust into the system, which of course means that we have to think off mainstream, because mainstream is done by politicians and media. And just to give you another example, in Germany as well as in Austria, opinions also of doctors like myself, but I'm not so important, but of doctors which are not mainstream are blocked out of the media. The mass media are not allowed to publish these kinds of perspectives. There is no discussion on it. It's only the mainstream thinking, and this is done by some virologists and the politicians. But this is bad news. We don't have freedom of media anymore. So it's up to us to ask for facts, to ask for solid information, and to judge on ourselves what can we do to protect those in need, but to let it flow in those who don't need it. I mean, if I get an infection and I don't even fall sick, why shouldn't I be infected? If I may contribute to what we call herd immunity, and if we want to reach herd immunity, we won't be able to do this by vaccination, no matter when the vaccine will be available. So I think we have to somehow to learn how to live with this infectious agent, to have some kind of coexistence, peaceful coexistence. And for those members of our society, it might be dangerous. They should be offered non-limited protection and help and assistance and whatever.
I think that a balance is so important. And as you say, we have a categorical imperative in terms of our responsibility to our patients as well, and to minimize that fear and panic, and to put things in perspective, and to help them actually understand so that they are able to enjoy life, as you say, and to at least socialize to a certain extent. And no doubt there are lots of things that we can debate further, such as the opening of schools and the time that the young children, the young 6-year-olds are missing out in terms of interacting with their peers and so on at school. This is another big debate that we could actually start discussing, but unfortunately, time doesn't allow us to do that. So I'd like to thank you very much for your time and insights into this interesting time in which we find ourselves. And I certainly hope that we'll be able to welcome you at our conference in October at Skukuza next year, and where we can further debate a year later as to where we are with this interesting viral infection. And hopefully it has been able to be in a situation where the true perspective has been adopted. Martin, thank you very much again for your time, and best wishes to you in Germany.
Garth, thank you very much for having me in this podcast. All the best to you, to your family, and to all those nice people in South Africa. Bye-bye. Thank you very much. Bye-bye.
Bye-bye.